Hey everyone, we've got another fantastic case study for you today. This patient has really acute and really irritable shoulder pain. I'm going to take you through their assessment and how I came up with their diagnosis. If you want to play along and put your clinical reasoning to the test, let's dive in. Hey everyone, Khalid here. Welcome back to Clinical Physio and really glad that you can join us for today's shoulder pain case study. So let's check out our patient. So let's look at the subjective history of our 32-year-old female who's presenting with a 2-week history of severe, really irritable right shoulder pain. And this is really affecting her because she's right-handed and it's affecting all the day-to-day tasks that she needs to do. So the key thing with this person's symptoms is that she did not have any specific injury, trauma, or any clear reason that she can remember that her symptoms came on. Instead, she reports that her symptoms suddenly got worse in the middle of the night. She woke up with this really acute, sudden, sharp pain in her shoulder. She doesn't remember doing anything particularly stressful the day before. She doesn't remember the week before being any different to any other week. She's just woken up with this really irritable pain. So bad, in fact, that once in the last 2 weeks, she actually went to the emergency department. She went to A&E to get her shoulder looked at. It was looked at by the orthopedic doctors who concluded that there was nothing serious going on and she was discharged from the emergency department with some painkillers to try and help her symptoms. Overall, she's got good general health, she has no major red flags, but she does have this really acute, sore shoulder that doesn't seem to have got any better across the last 2 weeks. So next, let's head through to the objective examination for this patient, and there seems to be a quite clear pattern to her presentation in that, unfortunately, lots of it is just so sore for her shoulder. So, whilst there was no specific points of tenderness found on palpation, we can generally see that the patient is just really struggling to move her right arm with any particular movements at all. She's visibly in a lot of pain, as the observation section suggests. We have a look at her active range of movement for her neck, her left shoulder, and her right shoulder. Neck range of movement, cervical spine range of movement, absolutely fine, pain-free, not bringing on any of her symptoms. Left shoulder range of movement, once again, totally comfortable for her. Right shoulder, significantly restricted in all directions. And for things like flexion and abduction, it was limited to only 20 to 30 degrees because it was so incredibly sore. Having looked at the active range of movement, we looked at passive range of movement, which unfortunately was exactly the same. And then we went on to do a couple of brief resisted tests, knowing that her shoulder was so sore, there's no need to really force these tests, but even just getting her to do a gentle isometric contraction against resistance clearly irritated her shoulder even more. So, we basically have a patient with really clear irritable symptoms that doesn't seem to have come on for any particular reason, and she's really struggling with her range of movement. What would you do next in this situation? What would be your management strategy, and what might be the diagnosis you think of? So everyone, I'll talk you through what I did. So, the fact that this patient has presented with such acute, severe, irritable symptoms with no clear onset at all makes me think of a couple of different things that it could potentially be. The first is potentially something rheumatological. However, we don't tend to find that in the younger age group, this tends to come on with the presentation this patient has had. We sometimes find that in the older age group, for those aged above 60, they can sometimes develop bilateral shoulder pain or unilateral shoulder pain as a key symptom of polymyalgia rheumatica, which can sometimes come on suddenly in the middle of the night and be really, really sore. But otherwise, the lack of trauma for this patient made me a little bit suspicious of the second thought, which might be something serious going on, perhaps like a tumour. However, thankfully, when I referred her for an X-ray to look for serious things, we found something which was much more reassuring, but also really explained her symptoms. And that was that her X-ray showed that this patient had signs of calcific tendinitis. So if we look at this X-ray, we can see this area just on the lateral aspect of the shoulder, which is where we can see calcium deposits, which is most likely to be in the supraspinatus tendon. And that was the clear sign that highlighted to us calcific tendinitis from this patient's X-ray. So with that diagnosis in mind, let's look back retrospectively at this patient's history to try and find out the signs of calcific tendinitis, because there was a few. First of all, we tend to find that this condition affects women more than men, and in the age group between 30 years and 60 years. And with this patient being 32 and female, it does fit within that bracket. However, perhaps the most clear sign that was consistent with calcific tendinitis is the fact that this patient woke up once in the night with this incredibly severe sore onset of symptoms. This is unfortunately quite typical for calcific tendinitis, where patients have no idea what's happened. They've been not doing anything particularly different in the days or weeks before, but they've just suddenly woke up with this really irritable pain at their shoulder. And that was certainly the case for this patient, and that fits into the pattern of this condition. Now, the other key condition to differentiate against is a frozen shoulder, because sometimes we find that patients wake up with really irritable pain with this condition. However, there is one very clear factor that reduces the likelihood and totally reduces the likelihood for me that this patient had a frozen shoulder, which is her age. Frozen shoulder very typically presents in the age group between 40 and 60, with the average age being around 50. So we absolutely do not expect frozen shoulder to present in a 32-year-old, quite simply because it's not consistent with the age that we expect for this condition. So I was quite confident that frozen shoulder wasn't the case for her. And the fact that she had had no specific injury, no specific trauma, she hadn't been doing anything differently in the days and weeks beforehand, suggested to me that she was unlikely to have a rotator cuff tendinopathy or an issue like a rotator cuff tear. And so all of this, and the thankfully reassuring X-ray that showed no serious signs going on, really allowed us to focus on the diagnosis of calcific tendinitis. So a very brief summary of some of the treatment options that are used for calcific tendinitis. First of all, you can imagine with the patient in front of you, whereby she has this really acute irritable shoulder, that sometimes doing physiotherapy exercises isn't actually the most optimal suggestion for them. It can just be way too sore because of the fact that they've got such high pain levels in the first instance. So therefore, pain relief is super important. When she went to the emergency department, they gave her painkillers, which unfortunately weren't helping her. And therefore, there are a couple of additional options available. The first might be a steroid injection, in which the patient receives a large dose of steroidal anti-inflammatories, which also is combined with a great big dose of pain relief. And these can often help the patient settle their symptoms down and hopefully allow them to move their shoulder a bit more. The other option that is commonly used is a barbotage procedure, which once again involves a needle being inserted into the patient's shoulder in order to try and break up the deposits of calcium around the shoulder so that we can reduce that calcium within the tendon and hopefully improve the patient's symptoms. Now, with both of these options, what we tend to find is that the calcium that is in the tendon gradually resorbs over time. The body naturally reduces the volume of calcium within the tendon by reabsorbing it. So thankfully, it's not something that has to be a really chronic condition, but the steroid injection or the barbotage can really help patients who have acute irritable symptoms just to get themselves back on the road, that they can start doing their exercises and get their shoulder better. So everyone, thank you so much for watching. I really hope you've enjoyed this video. If you have, please support us by smashing that like button. And remember, we've got loads of brilliant resources as well on our Instagram channel at Clinical Physio. You can follow us there. Now, if case studies is one of the ways that you learn best, make sure you check out our membership platform, member.clinicalphysio.com, where you will get access to the Case Study Club, The Case Study Club is a brilliant feature we have where we interview specialists in musculoskeletal physio, respiratory physio, and neurology physio, where they tell us about different patients that they've had in their practice and how they came up with the diagnosis and all the key clinical reasoning behind it. So if you like case studies, check out membership. You'll get access to the Case Study Club. Otherwise, thank you so much for watching as always. Look forward to seeing you soon here on Clinical Physio.